Spin Essentials, the core topics in pediatric neuroimaging essential for daily practice, packaged as our holiday gift to you.
In the next 20 minutes, my objective will be to help you negotiate some of the signs and symptoms associated with mid-layer pathology. I'm acutely aware that this list is not all-encompassing. This is a schematic illustrating the structure of the ear. The tympanic cavity is connected to the pharynx via the eustachian tube. It contains one tympanic membrane, two muscles, the stapedius and the tensor tympani, two nerves, the facial nerve and the cauda tympani nerve, three ossicles and their suspensory ligaments. Apart from trauma, infection, and inflammation, neoplasms like LCH and rhabdomyosarcoma can be responsible for mid-layer opacification. Before we delve into the pathology, a slide demonstrating the relationship of the ossicles to each other. On the axial acquisitions, starting from caudal and progressing craniad, we can appreciate a parallel arrangement of the neck of the malleus to the long process of the incus and the incudostapedial joint. Moving craniad, there are two dots situated posterior to the neck of the malleus, with that on the lateral aspect representing the lenticular process of the incus, and that on the medial aspect representing the head of the stapes, with the lucency in between them representing the incudostapedial joint. The next slice above is the well-known ice cream cone appearance formed by the malleus head and the cone that is formed by the body and short process of the incus. The coronal reformation to the extreme right shows a perpendicular arrangement with the vertical line formed by the long process of the incus and the horizontal formed by the lenticular process of the incus. Let's start with cholesteatoma. This is a picture of the tympanic membrane as seen through an otoscope. It has a superior part which is referred to as the pars flaccida, that is flaccid, and an inferior part which is referred to as pars tensa, which, as the name suggests, is tense. There are several theories behind the formation of a cholesteatoma. Eustachian tube dysfunction leading to negative pressure in the tympanic cavity is the basis of the retraction pocket theory. This pocket forms in the pars flaccida in the posterior aspect. It is in close relation to the long process and body of the incus. With growth and further accumulation of epidermal elements, there results an erosion of the scutum, the lateral aspects of the ossicles initially, and then an extension into the mastoid. This is a case of a pars flaccida cholesteatoma in a 3-year-old male with a discharging left ear and a left-sided conductive hearing loss. There is an erosion of the scutum, widening of Prosax space, medial displacement of the ossicles demonstrated by lack of the perpendicular arrangement, erosion of the ossicles on the left side also demonstrated by absence of the two dot sign, and a disfigured ice cream cone representing erosion of the malleus as well as the body and short process of the incus on the left side. We have a comparison image on the bottom left representing normal appearances. The sagittal reformations are extremely helpful in identifying erosion of the tegmen. Diffusion restriction and absence of enhancement are hallmarks of a cholesteatoma. The diffusion weighted imaging is acquired using a non-echoplanar imaging technique. There could be situations where there is a diffusion restriction and at the same time an enhancement. This would then suggest that there is a cholesteatoma along with a situation of granulation tissue. This is a case of a pars tensa cholesteatoma in a 4-year-old female with conductive hearing loss. Note the absence of the erosion of the ossicles as well as the scutum. The cholesteatoma is classically located medial to the ossicles, in contrast to the acquired cholesteatoma that is lateral to the ossicles, and the congenital cholesteatoma is less likely to cause erosions. A pars flaccida cholesteatoma can present as a polyp. This is a 15-year-old male with a right oral polyp. Note the erosion of the scutum as well as the ossicles. There is also an erosion of the superior semicircular canal along its lateral aspect. This is a slight variation on the theme in that the cholesteatomas tend to cause an erosion of the lateral semicircular canals. Apart from cholesteatoma and otitis media and retained grommets, Langerhans cell histiocytosis and rhabdomyosarcoma could also present as oral polyps. How do we differentiate between the two? Langerhans cell histiocytosis tends to occupy the posterior petrous and the mastoid, given that it is marrow rich, whilst the rhabdomyosarcoma tends to occupy the anterior petrous, given the presence of muscles such as the stapedius and tensor tympani anteriorly. This is illustrated in these two cases. The top panel is a 3-year-old male with granulation tissue on examination. The final diagnosis was LCH of the petrous temporal bone. We can see a destruction of the posterior aspect of the petrous temporal bone as well as the mastoid, a T2 predominantly hypointense mass lesion, which is avidly enhancing and diffusion restricting. The bottom panel is a 5-year-old male with left oral polyp. The final diagnosis was a rhabdomyosarcoma. This is a permeative destruction of the petrous temporal bone, predominantly centered anteriorly. The oral polyp, very nicely seen on the T2 weighted image. It's demonstrating enhancement and minimal restricted diffusion. Opacification of the middle ear could be due to cholesteatomatous or non-cholesteatomatous conditions. Erosions are commonly seen in association with a cholesteatoma. However, if they were to occur in a non-cholesteatomatous situation, they would tend to involve the long and the lenticular process of the incus and the stapedial head. The malleus and the body of the incus are less vulnerable. This is seen in this particular case of a 15-year-old female where there is chronic right-sided tympanic membrane retraction by the absence of parallel lines, which means the posteriorly situated long process of the incus is not visualized, absence of the perpendicular arrangement, presence of dehiscence in the tympanic segment of the facial nerve canal, and erosion of the tegmen. An MRI performed demonstrates no restriction of diffusion and presence of enhancement, therefore reinforcing the diagnosis of a non-cholesteatomatous erosion. This is a rare case of a partially opacified middle ear queried as cholesteatoma in an 11-year-old with conductive hearing loss. The CT demonstrates the opacification to be secondary to a mixed density mass lesion that appears like a calcified or an ossified mass containing internal trabeculations. Upon further inquiry, it was revealed that the patient had thalassemia, seen on these skull X-rays as a hair on end appearance. Therefore, we made the diagnosis of extramedullary hematopoiesis. This was confirmed on operation. This is a flow chart to systematically analyze the opacified middle ear. So, the opacified middle ear cavity could be due to infection/inflammation or a non-cholesteatomatous condition. It could be due to a cholesteatoma, or it could be due to neoplasms. And we've discussed in the preceding slides the various characteristics. Moving on to imaging the dysmorphic ear. To understand and analyze the dysmorphic ear and its associations, it is critical to understand the branchial arch embryology. There are 6 branchial arches. The fifth one is translational. Neural crest cells migrate from the midbrain hindbrain region to the branchial arches as shown in the figure. Thus, each branchial arch has a mesodermal core that is surrounded by neural crest cells. Each arch is separated from the other arch by an ectoderm lined branchial cleft on the outside and an endoderm lined branchial pouch on the inside. As shown in the figure, the ectoderm lined first branchial cleft gives rise to the external auditory meatus. The tympanic ring The malleus and incus are derived from the neural crest of the first branchial arch. The stapes is derived from the neural crest of the second branchial arch. The eustachian tube is derived from the first branchial pouch. At this point, I would like to draw your attention to the uh, schematic on your right, where structures in blue, i.e., the frontal bone, the sphenoid, the temporal, the maxillary, and mandibular, are also derivatives of the neural crest. Therefore, it is easy to understand that if there was a neurocrestopathy, we would have widespread involvement not only of the skull vault and the base of the skull, it would also extend to involve the petrous temporal bones and the ear. And this is what we see with complex craniosynostoses and several other conditions that we will discuss. This is a frontal view of the branchial arches. The first branchial cleft forms the external auditory canal. The cartilage of the first branchial arch is the Meckel's cartilage, which gives off the malleus and the incus. The cartilage of the second branchial arch is the Reichert's cartilage that gives rise to the stapes. Why do the malleus and incus fuse, or do they? The top panel shows the Meckel's cartilage giving off the malleus and incus as a fused structure at 13.5 embryonic days in a mouse. At 14.5 days, there is a joint between the two. The bottom panel depicts the Alcyon blue stain that shows the malleus and incus as a united structure at 13.5 embryonic days in a mouse. At 15.5 embryonic days, the joint marker GDF5 is expressed at the malleoincuidal joint. Upregulation of joint markers such as the GDF5 and BAPX1 is required for the joint to form. Failure of upregulation of GDF5 and BAPX1 can be associated with malleoincuidal fusion. The syndromes of the first and second branchial arches can also be interchangeably used with other terminologies such as hemifacial microsomia, craniofacial microsomia, otomandibular dysostosis. So, this is a situation where there is significant overlap, and therefore the term oculo-auriculovertebral spectrum was introduced. There are several differentials of the OAVS, Treacher-Collins, Townes-Brocks, Charge syndrome, bronchio-otorenal spectrum, and mandibulofacial dysostosis. Each of these syndromes has a particular finding that helps guide diagnosis. For example, Townes-Brocks syndrome has anal anomalies. Charge syndrome, as you all know, has semicircular canal anomalies and several others. The bronchio-otorenal syndrome have renal anomalies. Mandibulofacial dysostosis tend to have esophageal atresia. Similarly, Goldenhar syndrome, a variant of craniofacial microsomia, tends to demonstrate epibulbar dermoids and vertebral anomalies. The first and second branchial arch syndromes affect all structures of the hearing apparatus. There is bilateral anotia in the patient with Treacher-Collins syndrome along with craniofacial microsomia. On the right is a patient with Goldenhar syndrome with a unilateral left-sided microtia, hypertelorism, and a left craniofacial microsomia. Moving forwards, the patient with Treacher-Collins syndrome has absent ossicles, and because the ossicles are absent, there is a lack of stimulus for the oval window to develop. Hence, there is oval window stenosis. There is also a cleft palate and abnormality of the condyles. On the right side is the Goldenhar syndrome patient with bony atresia of the external auditory canal, a malleoincuidal fusion on the contralateral side, fusion of the incus to the lateral bony plate on the left side, and a cleft palate. Occasionally, Goldenhar syndrome can reveal anomalies that are unrelated to the branchial arch derivatives. We have a pericallosal lipoma and a low-lying tethered cord in a companion case. The clinical photograph, unrelated to the previous two images, is to show another tethering effect which is manifested as a preauricular tag that is low and an angle of the mouth that is pulled up. This suggests that Goldenhar syndrome could be a disorder of ectodermal non-disjunction involving cell adhesion molecules. When Goldenhar is bilateral, it can be difficult to differentiate it from Treacher-Collins syndrome. However, it is important to note that Treacher-Collins syndrome has no ocular anomalies. This is a 16-year-old male with right-sided microtia. Examination shows an absence of the stapes with a prolapsed facial nerve overhanging the oval window along with oval window atresia. The embryology of the oval window atresia is related to the development of second branchial arch structures, more importantly, the facial nerve. There are two theories. The first suggests the anterior and inferior displacement of the facial nerve preventing the stapes blastema from coming into contact with the oval window. The second theory suggests there is underdevelopment of the first arch and therefore an anterior shifting of the second arch structures, namely the stapes and facial nerve, to explain the oval window atresia. Both theories incorporate a normal development of the facial nerve as a prerequisite for the formation of a patent oval window. When reporting a case of microtia or anotia and its associations, it is obligatory to use the Yas-Dorfer scoring system, which has several parameters, and each parameter is given a score, and a total of 10 points uh, could be gathered if all those parameters are satisfied. Apologies for the busy slide. There are many genes that are involved in the first and second branchial arch syndromes at every step. You will notice in bold that, amongst others, the homeobox or HOX genes figure prominently. You can read this in leisure when the recording is made available. But I would like to draw your attention to a few genes here. Trickle, a product that is involved in Treacher Collins. Hawks, as I mentioned, that can be involved in cleft palate, apart from its involvement in Athabascan brainstem dysgenesis. The first and second branchial arch syndromes can be associated with anomalies of the ear, the auditory canal, the middle ear. However, as we have seen, there could be wider ramifications, as in the Charge syndrome, Goldenhar syndrome, and other differentials of the oculo-auriculovertebral spectrum. The malleus and incus are initially fused. They express SOX9 and type 2 collagen. A joint develops later as a result of upregulation of GDF5 and BAPX1. Therefore, failed upregulation can be the reason why the malleus and incus are fused. Normal facial nerve course is a prerequisite for the stapes and the oval window to develop. A properly formed stapes means a properly shaped and sized oval window. Moving on to imaging of tinnitus. An aberrant internal carotid artery, amongst other causes, is responsible for tinnitus. To understand the aberrant internal carotid artery, let's look at the vascular embryology. There are two ventral aortae and two dorsal aortae. Each ventral aorta is connected to its fellow dorsal aorta by means of arterial arches. There are six of these. The fourth arterial arch will form the aortic arch. The ventral aspect of the third arterial arch will form the common carotid artery, while the dorsal aspect of the third arterial arch will form the root of the internal carotid artery. The ventral aorta, situated proximal to the third arterial arch, will form the external carotid artery, while the dorsal aorta, proximal to the third arterial arch, will form the internal carotid artery. After this, the ventral part of the first aortic arch, called the pharyngeal artery, will unite with the dorsal part of the second arterial arch. This is known as the hyoid artery. After this, the hyoid artery will give off the stapedial artery, which will run through the stapedial crura. It gives off a cranial branch, which is the middle meningeal artery. It also gives off a caudal branch that unites with the internal maxillary artery. The point of anastomosis is where the foramen spinosum is. Also, the inferior tympanic artery will join the hyoid artery. Over time, the stapedial artery atrophies, transferring the middle meningeal artery to the external carotid system from the internal carotid system. The hyoid artery becomes the caroticotympanic artery. The ascending pharyngeal artery gives off the inferior tympanic artery. An aberrant internal carotid artery is when there is absence of the vertical segment of the internal carotid artery. Now, because the vertical segment is absent, the inferior tympanic artery supplies the horizontal segment of the internal carotid artery, and also it gives off the stapedial artery. The stapedial artery passes through the stapedial crura and then it continues as the middle meningeal artery. However, there is no caudal branch to anastomose with the internal maxillary artery, and therefore there is no foramen spinosum. Let's illustrate this aberrant internal carotid artery and persistent stapedial artery. This is a 5-year-old female with bilateral sensory neural hearing loss and tinnitus. There is absence of the vertical segment of the internal carotid artery. Therefore, we have a hypertrophied inferior tympanic artery shown on the plain CT as the enlarged right inferior tympanic canal, the contralateral inferior tympanic canal shown for comparison. This inferior tympanic artery enters the middle ear and via a curvilinear course drains into the horizontal portion of the internal carotid artery. In its retrotympanic course, it could be mistaken for a paraganglioma, therefore, imaging is very important. The persistent stapedial artery that is given off from this inferior tympanic artery runs through the stapedial crura and then enters the facial nerve and leaves the petrous temporal bone as the middle meningeal artery. This is visualized on this particular image, unrelated to this case, as a dot that is situated just behind the anterior crus of the stapes. It then enters the facial nerve canal, which appears wide, and after that it leaves the petrous temporal bone to continue as the middle meningeal artery, the contralateral canal shown for comparison. And since there is no anastomosis between what would be a caudal branch with the internal maxillary artery as shown in the schematic before, there is no foramen spinosum. Moving on, we have a 7-year-old female with bleeding following myringotomy. Hardly surprising given the fact that the malleus and incus are resting on a dehiscent jugular bulb. There is also a jugular bulb diverticulum in this case. There are several causes of tinnitus. The middle ear causes of tinnitus are aberrant ICA, persistent stapedial artery, jugular bulb variants, amongst others. Moving on to imaging the petrous apex lesions, we come to an 8-year-old female with earache and fever. An MRI demonstrates a right transverse sinus thrombus. Apart from enhancement in relation to the middle ear cavity and mastoid, a CT scan performed demonstrates grommet in the tympanic membrane plus opacification of the middle ear cavity and the mastoid. An MRI performed 3 days later, because the patient is not responding as expected, demonstrates those changes in relation to the middle ear cavity and mastoid. But what we see is a right-sided esotropia. Now, this raises the flag for a diagnosis of Greden-Ego syndrome that is characterized by otitis media, mastoiditis, abducens paresis or paralysis, and pain in the V1 V2 distribution, since the motor route is very close to the petrous apex. In the case of pneumatized petrous apex, the air cells are responsible for causing the petrous apicitis, but in the absence, it is thought to be the result of osteitis or leptomeningitis. 9-year-old male with conductive hearing loss receives an MRI, and we can see a T1 hyperintensity in the petrous apex, that is T2 hyperintense with a hypointense rim and no restricted diffusion. This is a case of a cholesterol granuloma, which is the result of either infection, trauma, or inflammation leading to hemorrhage, which in the presence of an obstruction to drainage and impaired ventilation results in breakdown of RBC and other tissue elements to deposit cholesterol and lipids. There is a differential for petrous apex lesions, amongst which is cholesterol granuloma, cholesteatoma of the petrous apex, asymmetric pneumatization, petrous apex effusion, etc. Finally, the touch me not lesions. Petrous apex effusion, the petrous apex cephalocele, and asymmetric fat in the petrous apex confirmed by a fat suppression sequence.